All right, so our objectives for today are we will work to explain the mechanisms of action, indications, and adverse effects of both antimetabolites and anti-tumor antibiotics. And then we'll work to recommend appropriate supportive care management for patients receiving both of these types of medications. Just to give a little overview before we dive into specific agents, antimetabolites in general are going to interfere with de novo synthesis of DNA and in some cases RNA. Certain antimetabolites will interfere with enzymes involved in DNA metabolism, and most of these mimic nucleotides and either interfere with the polymerase reaction or get incorporated into DNA, creating a misread codon or interfering with later replication. All of the medications we're going to talk about for antimetabolites, they do require that the target cell be in the growth cycle. And as you're probably familiar, many of these medications are used as part of combination chemotherapy regimens. The four major categories that we'll break the antimetabolites into for our discussion today are folic acid analogs, purine analogs, pyrimidine analogs, and then the hypomethylating agents. And as you can see, we do have a good mix of drugs that are used in both hematology as well as in solid tumor patients. So hopefully at least some of the info that we discussed today is going to be applicable to everyone's patients. So we'll start off with our folic acid analogs, and we're going to discuss methotrexate first, which we'll probably spend the most time on today. So this drug has a very interesting history, which actually dates back to the 1940s. So it was observed that many patients with acute leukemia had a serum folate deficiency. And as a result of that, investigators decided to administer folic acid to patients to see if that ended up helping with their disease. Unfortunately, it was discovered that this was not only ineffective, but actually led to worsening leukemia in these patients. So these investigators then tested the opposite hypothesis to see if blocking folic acid synthesis was beneficial. Sidney Farber and his colleagues, they tested aminopterin, which was the first antifolate, in PEDS patients with ALL. And they were the first group to report achieving remissions in this patient population. So they were able to achieve remission in 5 of 16 patients who they were studying. Unfortunately, aminopterin did end up having a poor side effect profile, and it did not lead to sustained remissions. So methotrexate was subsequently approved and has since become widely used over the years. In terms of the actual mechanism of action, methotrexate inhibits dihydrofolate reductase, which is an enzyme that typically converts dihydrofolate to tetrahydrofolate. The absence of reduced folates ends up preventing de novo synthesis of thymidylate and purine nucleotides, ultimately inhibiting synthesis of DNA and RNA. So methotrexate is unique in that it can be given orally, intravenously, as well as intrathecally. As you know, there are quite a few oncologic as well as non-oncologic indications, and we do see an extremely wide dose range for this medication. So you could see something as low as 5 milligrams weekly for a non-onc indication such as rheumatoid arthritis. Moving up from there, when we use this in GVHD prophylaxis, you're going to see doses like 10 to 15 milligrams per meter squared. And then our high-dose methotrexate is going to come into play when we see doses like 3,500 to 5,000 milligrams per meter squared in many of our leukemia and lymphoma protocols. You may be familiar with MTR. So in those patients with primary CNS lymphoma, we actually see a higher dose of methotrexate, which is typically 8,000 milligrams per meter squared. And then we go all the way up to 12,000 milligrams per meter squared for some osteosarcoma protocols. And in those cases, we do often meet our maximum dose. So we typically cap methotrexate at a max dose of 20 grams. When we talk about high-dose methotrexate, the exact cutoff varies a bit from one source to the other, but it's generally accepted that high-dose methotrexate is anything above 500 to 1,000 milligrams per meter squared. And the reason that we call out these specific doses is that they are universally fatal if leucovorin rescue is not administered to these patients. So we focus a lot on supportive care with high-dose methotrexate. We give sodium bicarb fluids to maintain a urine pH of greater than or equal to 7. And the reason for that is that methotrexate is insoluble in an acidic environment. So we're trying to prevent precipitation of drug in the renal tubules and subsequent renal damage. Typically, our leucovorin rescue is going to start about 24 hours after the start of methotrexate. However, you'll find in certain protocols that give the methotrexate over 24 hours as a continuous infusion that will usually push the leucovorin out to start at hour 36 or sometimes even 42. And then for patients who do have delayed clearance with renal damage, we can consider a drug called glucarpidase, and we'll talk about that a little bit more later. If you haven't seen this before, we do have a really nice clinical practice guideline related to high-dose methotrexate, and this is available on UConnect. It has a lot of helpful information related to methotrexate supportive care and monitoring, so we'll spend some time going through what's included here. In our adult patients, you'll see that they tend to come into the hospital having already started their urine alkalinization the day before admission. So several years ago, we started having patients take baking soda for 4 doses the day prior to admission, as well as a dose the morning of admission. And the goal of this is to try to decrease the amount of time it takes them to get to a urine pH of greater than or equal to 7 by the time they are inpatient. And there is a take-home medication built for this within Beacon, so you will actually see this show up on patients' med lists. When patients do get admitted to the hospital for their high-dose methotrexate, you'll see that our treatment plans include a sodium bicarb infusion, and that is going to start out at 150 mils per hour in all of our patients. It's going to be in a base of either sterile water or D5, and that largely just changes if there's a fluid shortage of one or the other. We typically run the bicarb for 4 hours prior to starting the methotrexate. And then these plans are also going to include sodium bicarb boluses, which will be available to nurses should they need it if the urine pH falls below 7. And then within the plan, you'll also see that there are frequent urine pH checks that the nursing staff will do a few hours after starting bicarb and then throughout the patient's inpatient stay until they've cleared their methotrexate. For peds, the urine alkalinization is going to be slightly different. So in peds, we actually use a straight sodium bicarbonate drip, and that starts at a standard rate of 0.15 milliequivalents per kilo per hour. And then the nursing staff is actually able to adjust this in order to keep the urine pH between 7 and 8, so they're able to increase and decrease that on their own. And then we have separate fluids for these patients, which we standardly start at 125 milliliters per meter squared per hour. In patients who have had delayed clearance, we might be more aggressive and use 200 mils per meter squared per hour to start. And the reason that we separate the bicarb and the fluids in peds is that it makes it a lot easier to obtain the appropriate urine pH, since you can titrate these separately, since there is such a major variability in patient size in our peds population. And sometimes with our teenagers, you can see fluid rates of 400 to 500 mils per hour. So it's nice to have the bicarb separate from this. And then the checks for urine pH are going to be very similar to what we talked about for adults. So leucovorin is a reduced form of folic acid, so it's able to restore active folate stores that are required for DNA and RNA synthesis and can therefore protect cells from methotrexate toxicity. One important thing to keep in mind with leucovorin is that if you do have a dose of 25 milligrams or greater, it is recommended that we give this IV rather than orally to ensure adequate absorption. And then a common misconception with leucovorin is that it actually helps get rid of methotrexate, but it's important to know that while this is going to help protect patients' cells from methotrexate toxicity, it does not actually play a role in eliminating the methotrexate. So this is the table that's included in our methotrexate clinical practice guideline, and it provides guidance on what action should be taken based on methotrexate levels as well as serum creatinine. You'll see that the one regimen that is called out here as having different goals in terms of what you want your 24-hour methotrexate level to be is hyper-CVAD, and the reason for this is that we're giving the methotrexate and hyper-CVAD as a 24-hour continuous infusion. So when the nurses are drawing that level, it's right when methotrexate has just ended, so that's why we allow for a slightly higher level there. Pharmacists do always keep an eye out for these levels in the serum creatinine. So once we see those results, if there are changes needed in the fluid rate or leucovorin dosing, we'll touch base with the team, or if the result comes back during the evening, then we will page the fellow or attending to discuss any changes that are needed. On B66, we do have a rule that methotrexate must be started by 2100, and we've done this in an effort to try to minimize the number of levels that are coming back really late. For our adult patients, this is the note template that's used by the pharmacy team when a patient's 24-hour methotrexate level and creatinine come back. So in addition to commenting on these results, the note will also include information about timing of the level in relation to when methotrexate was started. It will have an assessment of any drug interactions, renal function, and then urine pH. And then finally, it will include recommendations for any adjustments that need to be considered for the fluid rate or the leucovorin dosing regimen based on the algorithm in our guideline. The reason we don't follow the table in the clinical practice guideline for our PEDS patients is that the Children's Oncology Group, or COG protocols, actually have their own flow charts for managing high-dose methotrexate. So this is an example from a PEDS ALL protocol. And as you can see, it walks you through assessing the methotrexate level and creatinine, and then making sure that any changes to hydration are made. And then further down in the flow sheet, there are also recommendations for managing leucovorin dosing, and then for when it's appropriate to stop leucovorin and fluids. All right, so moving on to glucarpidase, which is the drug that actually gets rid of methotrexate from the body. This drug is a recombinant carboxypeptidase enzyme, which degrades folic acid and methotrexate into inactive metabolites. It does provide a non-renal pathway for methotrexate elimination, and it's dosed at 50 units per kilo as a single bolus. Second and third doses of this medication are not recommended because they have not shown clinical benefit and may also increase risk of immunogenicity. If you do ever end up needing to order this drug, it is recommended that you round the dose to the nearest 1,000-unit vial if at all possible due to cost. So at UW, our cost for one vial of glucarpidase is about $31,700. So let's say you have an 80-kilo patient, we're talking about close to $130,000 for the 4 vials of drug that would be needed to make that dose. Because of the cost of this drug and how rarely we use it, we don't actually keep this in stock in the hospital. So in the unlikely event it is needed, it's something that we end up getting drop shipped to us. In order for adult patients to be eligible for glucarpidase, they need to meet these methotrexate concentration requirements and also need to have evidence of impaired renal function. So these are the general cutoffs included in our guideline for when you might consider glucarpidase. It is important to note that if a patient's methotrexate level is already less than or equal to 1, we would not recommend pursuing glucarpidase. And it's also reasonable to consider other toxicities in addition to the renal dysfunction, so things like CNS toxicity, or if a patient has really severe mucositis. Those are usually the cases that we might seriously consider glucarpidase rather than patients who solely have an elevated level and a bump in their creatinine. And then cutoffs for when to consider glucarpidase in our pediatric patients, those are going to be outlined in specific COG protocols. Glucarpidase does not actually have an impact on intracellular methotrexate. So while we are using this as a rescue agent, we do still need to give leucovorin in order to protect the cells. So once you've given glucarpidase, you'll resume leucovorin at the dose you were using previously for at least 48 hours. It is important that we separate the doses of these two meds by 2 hours because leucovorin is also metabolized by glucarpidase. So we want to make sure that we are getting as much effect on the methotrexate as possible. And then after the glucarpidase is given, methotrexate levels will be artificially elevated for 48 hours. And the reason for that is that glucarpidase metabolizes methotrexate into an inactive metabolite, which gets detected along with the active methotrexate in the immunoassay. You'll also see that the creatinine can continue rising for several days after glucarpidase. And the reason for that is that the renal damage is already done and the glucarpidase itself is not actually going to reverse the renal damage, but instead is going to help get rid of the remaining methotrexate in the body. So it may take the patient some time for their kidneys to recover. In terms of when we consider it safe to send these patients home from the hospital, in our adult patients, we like to see a methotrexate level less than or equal to 0.1. If their level is less than or equal to 0.05, then we're able to discharge them with no further needs. You'll see in our guideline that if they have a level between 0.06 and 0.1, it's recommended that we send them with a prescription for leucovorin. So we do 15 milligrams every 6 hours. And we do also instruct patients to continue doing that sodium bicarb the same way that they were doing it prior to admission. So we have them do that just every 6 hours along with their leucovorin doses. And we instruct them to continue that until they get an outpatient follow-up level drawn within 48 hours of discharge. If we do send patients home with leucovorin, we try to encourage them to fill with our pharmacy at UW because this is something that a lot of local pharmacies don't carry. In terms of our pediatric patients, if a methotrexate level is less than 0.4 and they have not had any issues with delayed clearance, then they are actually able to go home at that point with no additional needs. So a higher level than we allow our adults to go home at. If peds patients do have any delayed clearance, then we wait until their level is less than or equal to 0.1. And this can vary a little bit from one COG protocol to the next. As most of you are probably familiar with, there are many different factors that increase patients' risk for having delayed methotrexate clearance. So renal dysfunction, which we already mentioned, third spacing, so if patients have pleural effusions, ascites, severe edema, the methotrexate can accumulate in that fluid and then takes quite a while to clear. So sometimes when we have a patient who's taking a really long time to clear and we're not sure why, we may end up doing imaging to see if they might have some sort of fluid collection somewhere. It is also helpful to advise patients to make sure they're really moving around and walking in the halls when they come in for their high-dose methotrexate, just to try to prevent that fluid accumulation. And then you can see hepatic dysfunction, low albumin, dehydration, and drug interactions can also be a major issue. So we'll spend a little bit of time talking about the drug interactions in more depth, because it is always really important to look closely through the patient's med lists when they come into the hospital. So other drugs can interact with methotrexate through a number of different mechanisms. This isn't an all-inclusive list, but we'll highlight some of the major ones that you're likely to see in your practice. So first we have displacement of methotrexate from protein binding sites. And drugs that fall into this category include things like sulfonamides and salicylates. So that's why we hold Bactrim and aspirin when patients come into the hospital for methotrexate. Drugs can also delay methotrexate clearance by increasing urine acidity and reducing renal tubular transport. So meds such as folic acid and ascorbic acid fall into this category. So if patients are on those supplements or on a multivitamin, we'll generally recommend holding those. And it's also important to keep in mind that certain drinks that increase urine acidity, such as soda, can be problematic if patients are consuming a lot of those while trying to clear methotrexate. The next type of interaction is meds that compete for P-glycoprotein transport, CYP450 metabolism, or renal excretion of methotrexate. And this includes meds such as NSAIDs, penicillins, and ciprofloxacin. So it's not that uncommon that a patient may develop neutropenic fever while they're in the hospital waiting for their methotrexate to clear. So it's important to know in that situation that when you're selecting an anti-pseudomonal antibiotic, we would want to avoid Zosyn, but would be okay with something like cefepime or meropenem from a drug interaction perspective. And then finally, we do have some other drugs such as PPIs that can delay methotrexate clearance, but the mechanism for that is less well understood. All right, so now we are going to move on from methotrexate. So we'll talk briefly about pemetrexed, which we see in regimens for non-small cell lung cancer as well as malignant pleural mesothelioma. So this medication inhibits a number of enzymes that are involved in folate metabolism and DNA synthesis. You can see that drug interactions, the list is much shorter than with methotrexate, but NSAIDs can decrease the clearance of pemetrexed. So it's ideal to try to hold off on those for at least a few days before and after pemetrexed doses. There is some required supportive care that goes along with pemetrexed. So first we have vitamin supplementation, and this helps to minimize myelosuppression as well as GI toxicity. So patients should take folic acid once a day, starting a week before their first pemetrexed dose, and then they'll continue that throughout treatment and for 3 weeks after the end of their pemetrexed. It's also recommended that they get vitamin B12 injections, again, about a week prior to starting pemetrexed, and then they'll get that roughly every 3 cycles. And the last med here is dexamethasone, which we give to minimize cutaneous reactions. So patients are going to take that the day before, day of, and day after their pemetrexed. Next, we have pralatrexate, which is not a drug we see frequently, but it can be used in peripheral T-cell lymphoma. So this medication inhibits dihydrofolate reductase, and you'll see that it has fairly similar supportive care in terms of that vitamin supplementation that we talked about with pemetrexed. So these patients are also going to be on folic acid as well as vitamin B12 in order to minimize myelosuppression. So just to highlight some of the major toxicities from the folic acid analogs that we discussed, methotrexate, as we're familiar with, can cause significant AKI. Mucositis is seen pretty commonly as well. We often see a bump in LFTs shortly after the infusion, and there can be some skin toxicity as well as sometimes some neurotoxicity. With pemetrexed, we can see arthralgias, rash. Pralatrexate, again, has some pretty similar side effects. And then for all of these medications, the dose-limiting toxicity is myelosuppression. And as we talked about with pemetrexed and pralatrexate, the B12 and folic acid supplementation can help to minimize the severity of that. This is just a summary slide of the folic acid analogs, some of the main indications we use them for, as well as reminders about the supportive care that we use with these medications, as well as a note of if dose adjustments are needed with certain organ dysfunction. Now we will move on to our purine analogs. So we'll start with mercaptopurine and thioguanine, which are used commonly in our ALL patients. So these are structural analogs of purine bases, which undergo conversion to substrates that get incorporated into DNA. So these are inhibiting both DNA and RNA synthesis. You can see that there are multiple mechanisms of resistance with these medications as well, and we'll talk about those a little bit more in a future slide. Adverse drug reactions to be aware of with these medications include myelosuppression as a dose-limiting toxicity. And then it's important to know that patients who have a thiopurine methyltransferase or TPMT deficiency, as well as patients with an NUDT15 deficiency, and this one in particular is seen more commonly in Hispanic, Native American, and East Asian populations. But these deficiencies can lead to increased systemic exposure and to very severe myelosuppression. Hyperuricemia is also a potential side effect with these drugs. And the reason we're worried about that is that 6-MP is metabolized to an inactive metabolite by xanthine oxidase. So there is a really significant drug interaction with allopurinol, since that is a xanthine oxidase inhibitor. So if patients do require both of these medications at the same time, the 6-MP actually needs to be reduced to between 25 and 33% of the typical dose. But if it's at all possible, we prefer to just avoid the combination altogether. And then some other side effects that we can see with these meds are increased LFTs, mucositis, as well as rash. This slide just demonstrates where the various enzymes come into play with 6-MP and where we can run into problems. So you can see that HGPRT leads to an active metabolite, which is why a deficiency in this enzyme is a mechanism of resistance for 6-MP. Then on the left side of the slide, we see that TPMT leads to an inactive metabolite. So patients with that deficiency aren't going to be able to break down the drug effectively and will therefore have higher levels of active drug in the system. And then finally, with the xanthine oxidase, this leads to an inactive metabolite as well. So that's why it's problematic to have patients on allopurinol, so a xanthine oxidase inhibitor, and which will end up preventing conversion of 6-MP to those inactive metabolites. Our next drug is pentostatin, which we can see used in hairy cell leukemia. So this med is going to inhibit adenosine deaminase, and it blocks DNA synthesis and leads to cell death. Significant drug interactions here are myelosuppression as a dose-limiting toxicity, and this does suppress T helper cells, so puts patients at risk for opportunistic infections, and then patients can also experience rash, fatigue, and headache. Next, we have cladribine, which we see in AML as well as hairy cell leukemia. This is a prodrug which requires intracellular phosphorylation to become active. It gets incorporated into DNA and leads to DNA strand breaks and inhibition of DNA synthesis. Dose-limiting toxicity here, you'll see a common theme. So again, this is myelosuppression. Patients are also significantly immunosuppressed when they are on cladribine, so it actually causes a decrease in CD4 and CD8 cells that lasts for years, so putting them at risk for opportunistic infections. And then nausea and rash are common with this medication as well. Clofarabine we see in acute leukemias. This is going to inhibit ribonucleotide reductase, terminate DNA chain elongation, and inhibit DNA synthesis and repair. Again, the side effects include myelosuppression, infections, increased LFTs. We can see some GI and derm toxicities, and then you could potentially see cytokine release syndrome and more rarely capillary leak syndrome with this medication. Next, we have fludarabine, which we see in CLL. We see it commonly in BMT conditioning regimens, as well as now in lymphodepleting chemotherapy prior to CAR T-cell. So mechanism of action here, this is going to inhibit DNA synthesis and elongation of DNA strands, and also inhibits RNA polymerase. The dose-limiting toxicity here is myelosuppression. Other side effects can include fever, diarrhea, and neurotoxicity. And this neurotoxicity can be confusion, somnolence. Some patients could experience sensory issues or vision problems. And then it can also be as serious as seizures or even more severe toxicities. So definitely something to be aware of as a possibility. And it is more common at higher doses and can also be a delayed toxicity. Nelarabine is a medication which gets incorporated into DNA and inhibits DNA synthesis. It does accumulate in higher concentrations in T cells, which is why we use this in T-cell ALL as well as T-cell lymphoblastic lymphoma. You can again see neurotoxicity with nelarabine. So it's often described as dizziness, somnolence. Patients may experience a headache, neuropathies, or seizures. And then again, we're going to see myelosuppression. Some patients do experience flu-like symptoms, as well as elevated LFTs and edema. So again, this is just a summary slide for your reference, going through common indications that we use these medications for, as well as times that we may need to dose adjust, such as with a TPMT deficiency or renal or hepatic dysfunction. Next, we will move on to pyrimidine analogs. We'll start with 5-fluorouracil, or 5-FU. So as you guys are probably aware, we see this in a variety of adult solid tumors, particularly with GI cancers. And this is also used in pediatric patients who have hepatoblastoma. So 5-FU gets converted to 5-FDUMP, which binds to thymidylate synthase and results in suicide inhibition of the enzyme. This ultimately leads to deficiency in thymidine and inhibition of DNA and RNA synthesis. We also have capecitabine, which is an oral prodrug that gets converted to 5-FU in vivo. And then floxuridine is a chemical analog of 5-FU, which is actually administered as a continuous infusion into the hepatic artery. I did want to touch on DPT deficiency, which is important with fluorouracil and capecitabine. So patients with this deficiency have increased side effects such as cytopenias, worse mucositis, and significant diarrhea. 3 to 6% of people do have a deficiency, but routine testing is not generally done. This slide illustrates that DPD breaks 5-FU down, but with a deficiency, you're going to get less of the 5-FU broken down, so more of that drug and cytotoxic metabolites are going to hang around and cause severe toxicity. When we talk about side effects for these medications, we'll first start with infusional 5-FU and capecitabine. So dose-limiting toxicities here include hand-foot syndrome, stomatitis, and diarrhea. Some patients do also have nail changes, and photosensitivity does occur. And then a unique side effect here is angina that can occur with 5-FU. And it's thought to be due to coronary artery vasospasms that occur during or shortly after the 5-FU infusion. With bolus 5-FU, our dose-limiting toxicity is going to be myelosuppression. So it is important to be aware that the 5-FU toxicities vary based on how the drug is given. So then you'll know if you have a patient who is on Folfox or FOLFIRINOX who comes to clinic, and maybe you find out that they don't meet treatment parameters for blood counts, you'll then know that it's going to make more sense to drop their 5-FU bolus rather than making any adjustments to their continuous infusion 5-FU. And then we have fluoxuridine, so you're going to see similar toxicities with stomatitis, diarrhea, and myelosuppression. There is an antidote to be aware of that is called uridine triacetate. So this drug is used to decrease the toxicity to our blood cells as well as the GI mucosal cells and reduce fluorouracil toxicity in normal tissues. There are restrictions for this medication through P&T. So this can be used either following a fluorouracil or capecitabine overdose, regardless of whether the patient's having symptoms, or can be used if patients are having early onset severe or life-threatening toxicities, such as severe toxicities like GI or neutropenia. Doses of this medication are given orally, and it's given every 6 hours for a total of 20 doses. It's recommended that this be started as soon as possible after an overdose or after the onset of severe toxicities, and it's approved for use within 96 hours of the end of those drugs. It is important to know that this medication is very costly, so currently the cost of a treatment course with uridine triacetate would be about $80,000 for UW. Again, we just have a summary slide here going over common indications that we use these medications for. There are a few things on this slide that I want to point out within the table. So first, it's important to know that with 5-FU, when we're using leucovorin, we're actually doing this to enhance the cytotoxic effects of 5-FU. So leucovorin stabilizes the interaction between 5-FDump and thymidylate synthase, so ends up enhancing the overall activity rather than when we're using leucovorin with methotrexate as a rescue agent. There is also a significant drug interaction between both 5-FU and capecitabine with warfarin, so that's something important to know if you do have a patient on warfarin and are starting one of these medications. So these chemo agents inhibit CYP2C9 and therefore are going to lead to an increase in INR. Next, we will move on to cytarabine. So we see this used in a variety of heme malignancies. Cytarabine gets incorporated into DNA and inhibits DNA polymerase, blocking DNA elongation and ultimately leading to apoptosis. Next, we have gemcitabine. So this is used in several malignancies such as pancreatic cancer, breast cancer, and lymphomas. This medication inhibits DNA polymerase as well as RNA reductase, prevents DNA repair, and contributes to DNA strand termination and ultimately causes apoptosis. There are some pretty unique toxicities with these agents. So we'll start with cytarabine, where again, we're going to see myelosuppression as the dose-limiting toxicity. Patients can also develop rash, and this is often delayed. They can also have fever with cytarabine, nausea. Ara-C syndrome is rare, but when it does happen, it typically occurs 6 to 12 hours following Ara-C administration, and patients may report things like fever, muscle, bone, and chest pain, as well as rash and malaise, and this does tend to respond to corticosteroids. When we talk about high-dose cytarabine or high DAC, we're referring to doses between 1,000 and 3,000 milligrams per meter squared. The unique toxicities here include cerebellar toxicity, so patients may have impaired balance or coordination, may have slurred speech. So our nursing staff does complete neurochecks prior to each dose of high-dose cytarabine. and it is more likely to occur in older patients or patients with renal dysfunction. The other unique toxicity with high-dose cytarabine is a chemical conjunctivitis. So you will see corticosteroid eye drops built into these treatment plans. And at UW, we use prednisolone eye drops in our adult patients and then dexamethasone eye drops in peds. Moving on to gemcitabine, again, you're going to see myelosuppression as the dose-limiting toxicity. Patients may report flu-like symptoms. Elevated LFTs are pretty common. And patients can develop interstitial pneumonitis with gemcitabine. This does usually respond to corticosteroids. And then hemolytic uremic syndrome is a very rare complication, but if it were to occur, it would require discontinuation of the drug. The one thing I did want to point out on this summary slide is with gemcitabine, we usually administer this drug over 30 minutes, and it has been found that prolonging the infusion time to greater than 60 minutes can significantly increase myelosuppression, so just something to be aware of. Next, we're going to move on to hypomethylating agents. We'll start with azacitidine and decitabine. So these are seen in patients with MDS as well as some of our AML patients, especially if they're unable to tolerate more intensive therapy. The mechanism of action is very similar for these two medications. So they get incorporated into DNA, cause demethylation of DNA, and ultimately lead to apoptosis. With azacitidine, you can also see some direct cytotoxicity, and then decitabine is going to cause double-strand DNA breaks. The side effect profiles of these two medications are very similar. You'll see that with azacitidine, we can have injection site reactions since this is typically given sub-Q. And then with decitabine, it is slightly more likely that patients could develop a rash. Again, just a summary slide for your reference on some of the dose mods that need to be made based on organ dysfunction. And then we do actually have a brand new medication that was just approved by the FDA last week for MDS. And this is actually an oral drug. It comes as a tablet that contains 35 milligrams of decitabine and 100 milligrams of cedazuridine, which is a cytidine deaminase inhibitor. The recommended dosing for these patients is just a single tablet daily on days 1 to 5 of a 28-day cycle. It should be taken on an empty stomach, and it has a side effect profile that's pretty similar to IV decitabine. So I just wanted to make sure to at least mention this new agent. Finally, we will finish up with anti-tumor antibiotics. So this includes bleomycin, mitomycin C, dactinomycin, and then anthracyclines, but you will be covering anthracyclines in one of the other PCAL lectures, so we won't go over those today. Starting out with bleomycin, which we're going to see commonly in Hodgkin lymphoma in ABVD, and then the other big place we see this is in germ cell tumors in DEP. Bleo is going to produce single and double-stranded DNA breaks through generation of oxygen-free radicals. The dose-limiting toxicity here is unique, and this is pulmonary toxicity. This can often start as pneumonitis, but could potentially progress to pulmonary fibrosis, so it is something that's taken very seriously. We do get baseline PFTs in patients before starting bleo and then periodically throughout treatment. The risk of the pulmonary toxicity does increase with age, as well as with decreased renal function and with higher cumulative doses, so especially with a total lifetime dose of greater than 400 units. Some other interesting things with this toxicity are that supplemental oxygen exposure can exacerbate bleomycin pulmonary toxicity. And then there are some conflicting reports on whether or not G-CSF use with bleomycin puts patients at greater risk of pulmonary toxicity, but you will see in some of the regimens where we use bleo that it's not uncommon to see G-CSF built into these plants. Other adverse drug effects with bleomycin include mucocutaneous toxicity, fever, hypersensitivity, and then hyperpigmentation of skin. And with bleomycin, it is standard to pre-medicate with both diphenhydramine and acetaminophen. Mitomycin C is something you may see in bladder cancer, hepatocellular carcinoma, or a few other malignancies. It induces DNA cross-linking and inhibits DNA synthesis. Myelosuppression is the big toxicity here, and then you could less commonly see stomatitis, HUS, or pulmonary toxicity. Finally, we have dactinomycin. So this is used in Wilms tumor in pediatric patients, and then also plays a role in certain sarcomas, such as Ewing sarcoma and rhabdomyosarcoma. Dactinomycin binds and gets incorporated into DNA, preventing replication. The adverse drug reactions here are myelosuppression. There can be significant nausea and vomiting, increased LFTs, stomatitis. Radiation recall is a concern with dactinomycin, and then mucocutaneous toxicities. And then in this final summary slide, there are a few unique things that I wanted to point out with these agents. So starting with bleomycin, this drug is dosed in units, so just something to be aware of since that is not the norm with our chemo agents. It can also be given intrapleurally for malignant pleural effusions as a sclerosing agent. With mitomycin C, some of the unique things here are that this can be given by intravesicular instillation for bladder cancer and also by transcatheter arterial chemoembolization, or TACE, for hepatocellular carcinoma. And then with dactinomycin, the dosing here is often expressed in micrograms, and we often cap the dose at somewhere between 2,300 and 2,500 micrograms. And then another thing to be aware of is that you may need to either reduce or omit doses of dactinomycin if this is given during or shortly after radiation, because this med can potentiate the effects of radiation and lead to more severe toxicities.